Good morning, dear speakers, dear guests, colleagues, and fellow public health experts and enthusiasts all across Europe. It's a pleasure and honor for me to host you today for the duration of this exciting session, where we'll be discussing on our current understanding and different aspects of diabetes care together with our global public health experts and speakers. My name is Omar Saka. I'm a partner at PwC in charge of healthcare and life sciences policy. I'm a physician myself and spent the earlier years of my career actually researching on different aspects of cardiovascular and cerebrovascular diseases. And obviously diabetes plays a massive role in anything that affects our chronic longevity and chronic health and longer health aspects altogether. Thanks to all of those who were involved in setting up this session today. This webinar is taking place during an important occasion, the European Public Health Week. If you haven't come across and if you haven't actually checked the Public Health Week, please do so, because the week started this Monday. Obviously, the theme of the first day was mental health for all. Yesterday was diversity in health, and today the focus is going to be access to care. Tomorrow, another very relevant topic, prevention and control of chronic diseases. And on Friday, it's global health emergencies and response. Again, a very timely and very important topic taking place during the time of the World Health Assembly. Like I said, today's theme is access to care. And access to care, of course, is fundamentally the most, probably the backbone of how, especially within the European healthcare financing systems, how we enable citizens from an equitable manner to have the right therapies, the right preventions, the right diagnostics that befit their health profile. I'm saying health profile rather than sickness profile, and I think we're going to discuss that quite a bit today. But of course, access to care comes with all the luggage beforehand, all of the technical knowledge, all of the scientific knowledge, the evidence-based medicine knowledge that lines the lanes of access to care. And of course, it should be followed by the right processes and the right state of recognition, managerial recognition of the needs for the access to care to be in place, so that not only the policies and the rules, but also the practices meet the needs of the patients. I'm saying patients, but obviously I'm making a mistake. I was forewarned. I should really be saying to take care of the health of the society in Europe, but of course as the society at large. Today, there is actually a voila moment as well. I'm not going to take all the credit, but my colleagues and my friends and a wider group of our network, we are launching an important report that we feel it's important. It's titled Revealing Policy Barriers in Diabetes Care, How We Can Improve Outcomes. The report is actually going to be launched today. You can access it on PwC's or European Federation of Pharmaceutical Industry Association's website, EFPIA. This report is a result of the congregation and the common working discipline between PwC and EFPIA, and we've carried out all of our research and methodological investigation on the provision of diabetes care across Europe under the auspices of European Diabetes Forum. I think I don't need to underline the importance of the timing, also because recently the new diabetes guidelines have been launched, and we actually kept our focus on understanding the path on implementing, not necessarily, of course, criticizing anything scientific. We leave the scientific background of the diabetes guidelines to the experts, but our focus was validating is identifying the paths to validate, to translate, and adapt the clinical guidelines into clinical practice across Europe. And we have some very interesting findings. My colleague, Dr. Claudio Vittori, in a few moments will take you through those findings. Therefore, the sequence of the day is Claudia will take the microphone in a minute. She's going to take us through the findings. That will lay the foundation of our conversation, and we'll have a number of questions for our global public health experts. Namely, we have Professor Stefano Del Prato with us today. He's a diabetologist. He's a professor of endocrinology. He is the past president of European Association for the Study of Diabetes and the current chair of the European Diabetes Forum. We have Dr. Maurizio Guidi. He's Associate Vice President at Eli Lilly. He's in charge of diabetes and obesity and corporate affairs, and he's also the chair of the EFPIA diabetes platform. And we have Ms. Sandra Sandas. She's a psychologist and she's a manager at the Diabetes Association of Catalonia. We also have honorable gentleman, a member of the European Parliament, Mr. István Ujhelyi from Hungary. He's a member of the Party of European Socialists, and he's a member of the members of the European Parliament Mobilizing for Diabetes Initiative. We're going to welcome him to our session at 1 o'clock. Now, before handing out the microphone to Claudia to lay the groundworks of our findings, allow me to say that we are really looking forward to the conversation with open questions to our experts. You will also be given, the participants, the wider audience, to ask questions. There is actually a box that says audience chat. I think Sophie just sent a message to all of you, welcoming all the guests to this session. This chat will be publicly available to everyone who has registered to participate in this session. So if I could please remind you and request that we stick to the general rules of respect and decorum, and we keep the etiquette of our conversation and our thoughts and perspectives within that manner, respecting our speakers and of course respecting everybody's perspective in this particular session. On that note, Dr. Claudia Vittori. Claudia, may I please pass the microphone to you?
Thanks a lot, Ömer, and welcome everybody. We are happy today to share some of the highlights from our study. So first of all, you will hear today a lot the term barrier, and we just want to make some clarity what we mean by barrier. That's quite intuitive. We mean those factors that act in real life as impediments and obstacles to the implementation of clinical guidelines into clinical practice. And you see on this slide, we list a few examples, and we categorize these barriers into three broad categories. So starting from the top, we have factors related to the guidelines themselves. And very simply, guidelines might be complex to read and understand and implement, or they might describe patient pathways that are actually far from clinical pathways that you would find in real life. We have a second category of barriers that are so-called behavioral. We hear a lot about this sort of barriers. They can be on the patient side or on the healthcare professional side, and we hear about education and health literacy. These are also important factors which might determine the lack of full implementation of clinical guidelines in real life. And finally, we have a third category, which we refer here as structural or systemic barriers, which include all those factors that relate to the way healthcare systems are organized, healthcare is delivered, or prescription is actually enabled. So in few words, these are all those barriers that depend on a policy and really on the action by decision makers, policymakers. On the right side here, you find a representation of what our experts believe is the impact of each of these categories on the ability to implement clinical guidelines in real life. And this is also captured in the literature. There's not a huge body of evidence around this, but it's clear also from the literature and from our research that structural and systemic barriers are the main impediment in type 2 diabetes management to the full application of clinical guidelines. So it made sense for us to go and dive into this category of barriers. So you see in front of you the main bulk of our study, our taxonomy. The taxonomy we built around different policy-related barriers you find across Europe. So what we did was really to take a sample of European countries and try to identify describe and categorize, if you like, different types of policy-related barriers and their impact. And you see them organized here under 3 categories: guidelines-related, access-related, process-related. And briefly for your reference, first category, guidelines. We don't speak about guidelines themselves, but the policies that are needed to actually implement those in real life. Once international guidelines are published, they need to be translated, adapted, validated by countries. And all these processes, while they're needed, they might also introduce some deviance and some disconnect from the original guidelines due to the way each healthcare system is designed. It might also end up, especially in regionalized healthcare systems, as a very fragmented guidance at the regional or local level. Second group of policies we identified are access related. So these are the most visible and probably discussed type of barriers, and I'm sure most of the audience is very familiar and won't find anything really new in the list in front or shared on the screen. What was surprising for us is how each of these categories of barriers actually build on top of each other and may end up as represented a huge hurdle for healthcare professionals and people with diabetes altogether to actually implement therapeutic choices. And finally, process-related, this is a bit a broad category. We include here all those processes that have to do with the organization of care delivery or prescription processes. And maybe an example I can make here, which is quite interesting. In most countries, in order to manage type 2 diabetes, there's a need to fill a therapeutic plan. While in some countries, this is basically a blank form that the prescriber can fill. In other countries, there's a software which is indicating therapy choices, therapy suggestions based on clinical data which are entered. And if the healthcare professional, based on the patient history or based on the clinical guidelines, would like to make a different choice, that may turn up to be quite complex and burdensome and lengthy for a healthcare professional to do. So altogether, all the policies you see listed in front of you can represent some real-life obstacle to the implementation of guidelines. And I just would like to note, we are not naive and think that these are these policies might have only negative effect on the ability to implement guidelines. Obviously, most of these policies are needed and are there for a reason. What we are doing here is to highlight how in real life, the way some of these policies are designed might create a disconnect or a gap between what the scientific evidence is suggesting and what's possible actually in real life. So what we also found out in this study is that policies are extremely fragmented across Europe. And you see in front of you how each of the categories I described, or you could see in the previous slide, which are now in rows, end up having a different impact across countries. So you can read in the report the full methodology and approach we took in order to build this heat map. But what you see is a prominent outcome of this assessment is that there are large discrepancies across Europe. Policies are fragmented and they might have different impact across countries, which can build the ground for uneven access to quality care or even uneven outcomes. Finally, towards the end of the report, we indicate, based on expert input and the diabetes community more general, some principles for actions and some quite specific recommendations for local decision makers, national decision makers, as well and specifically related to type 2 diabetes management, as well as other broader recommendations at the health system level to improve care holistically for people with diabetes. And just briefly on this slide, you find some of these suggestions for local policymakers, at least suggestions for their consideration. So first, we found several examples of complex and redundant, cumbersome processes that healthcare professionals and people with diabetes might deal with. These processes do not really bring an advantage or any value to the system. There are no savings attached, but they might introduce delay and frustration. So there's definitely ground to improve some of the underlying processes related to diabetes management. Again, in type 2 diabetes, there has been great innovation in the last 10 to 15 years, and an interesting body of literature emerging showing the longer term outcomes related to the use of such innovation in the clinical practice. And the recommendation here is to review regularly emerging body of clinical and health economic evidence related to the different therapeutic tools that are available for management of diabetes. The last two principles you see, or suggestions you see here, are really stemming from the latest edition of the guidelines for type 2 diabetes management, in which two principles are announced pretty strongly, and I'm sure the experts later are gonna discuss about this. And these are the early intensification of treatment for specific patient populations, which may include the combination of different therapeutic strategies concomitantly. So this is not new, but definitely it's made stronger in the latest edition of the guidelines. And similarly, eligibility for certain therapeutic options is not depending strictly on one risk factor, which is glycemic levels, but other risk factors too. So again, the experts are definitely going to comment on these aspects. So I think this is what you probably need for this discussion. And I hope this helped a bit illustrate our main findings and messages, and really invite you to read the full report later on. If you have questions, I will try to answer in the chat, or later on we can follow up. Thank you so much. Omar, back to you.
Thank you. I think the voila moment has already started. Just to remind you, the name of the report is Revealing Policy Barriers in Diabetes Care, How We Can Improve Outcomes. If you just was to search this in your browser, I think you're going to come across with our website or FPIA's website to be able to find the report and have the chance to read it from today onwards. Now, we're going to move on to the Q&A session, just to perhaps update our audience on how we've structured this Q&A. I think in the first, we've got 4 blocks of conversations we've anticipated. The first one is we're going to take you through a bit of a setting the scene, a bit of the latest updates in diabetes management. And second block of conversation, we'd like to focus specifically on the policy barriers that stand in the way of adhering to guidelines. Claudia alluded to our observations in the report already. Again, Claudia alluded to, and which is going to make the third block of our conversation today, what are the potential solutions that may actually improve the situation, that eradicate the barriers and allow a better healthcare prospect for people suffering from diabetes or even pre-diabetes, or anyone with hopefully not walking that line yet, but also trying to avoid the consequences of the disease. And finally, as a final block, we're going to look at the outlook for diabetes management into the future, open with the new guidelines, but also thinking about the new therapies and new technologies that could be available to us. Now, on that front, on that line, I'd like to start with Stefano, if I could. Stefano, just to kick start the conversation, maybe I'm going to start with a general question. How did the knowledge around type 2 diabetes and therapeutic management of hyperglycemia in type 2 diabetes evolve along the years, in your opinion? What's the impact of the latest guidelines? Does it capture the novel evidence? Could you give us a bit of the lay of the land in that regard so that we can base our conversation as we move along? Thank you. Stefano, yes, you're on.
Mer, sorry, but I need you to repeat your question because
absolutely.
I started hearing you in the middle of your sentence.
I apologize. Let me go. It's not a problem. Just a very setting the scene question, really. The question is, how has the knowledge around therapeutic management of hyperglycemia, therapeutic management of type 2 diabetes evolved along the years, perhaps especially in the past 10, 15, 20 years, especially with the emergence of very novel therapies, of course? And what's your opinion, the contribution of the latest guidelines? Does it capture the novel evidence? Would it have to be further enabled for its implementation? If you could give us a bit of a lay of the land, I was wondering.
Sure, I'm more than happy to do that. And first of all, apologies, but I tried to be in time and I got stuck on the highway in spite of the fact that I left earlier on. Anyhow, I think that you mentioned guidelines, and I think that if you just look and know what has been the evolution of the guidelines, you can use that evolution to try to answer your question. Now, I'm particularly referring to the ADA-EASD consensus for the treatment of hyperglycemia in type 2 diabetes, which started off in 2006. If you go back at that time, the recommendation was the goal for the treatment of type 2 diabetes is good glycemic control. Glycated hemoglobin below 7, based on the result of the UK PDS, and so on and so forth. But now, if you look at those data, those are generated by the evidence. The evidence at that time were based on an armamentarium, a therapeutic armamentarium that was sort of limited. Now, with the turn of the century, we have been experiencing and witnessing an explosion of new opportunities. Not only that, but those opportunities, the opportunities, have been evaluated and validated not only in terms of glycemic control, not only in terms of safety, but also and even more with respect to potential cardiovascular and cardiorenal protection. So the guidelines, what they do with the guidelines and the right of the guidelines is to incorporate into the guidelines the evidence. And the evidence has moved from treat properly glycemia, which still remain, important for the reduction of the risk of microvascular complication, but also look at type 2 diabetes as a more comprehensive condition, as sort of a syndromic condition, where the task really is to reduce the burden of potential complication. And what has been the evolution is just to move toward a holistic view. So where you try, of course, to treat people with respect to their hyperglycemia, but also to consider what is the focus on regulation of the body weight, and even more in trying to take advantage of all those action of the new therapeutic agents that may exert on cardiovascular risk factor, and even more in those people who already had a cardiovascular event. So I think there is really a major evolution, if not a revolution, in the guidelines, moving from a glucocentric approach to a more holistic approach. Now, your other question, Omer, was, what is missing in the guidelines? Guidelines are not missing anything because the guidelines incorporated the evidence. What is missing, I believe, is proper implementation of the guidelines in the different health system. And that, I think, where we should really try to work on. Two main lines. Just make sure the guidelines promptly adopt all the evidence that's made available. And, the other one is just to implement to the best of the possibility that guidelines. And if you want, we can discuss, because there is a number of potential hurdles that may reduce the potential for implementing in a more efficient manner the guidelines currently available.
Oh, absolutely. Absolutely. Thank you. We know we're going to get to that. Mauricio, do you mind if I have you on at this stage? I think Claudia mentioned specifically on the basis of the guidelines, the implementation in different European countries lacks some unification, some homogeneous approach, and perhaps even, as Stefano very rightfully said, this holistic understanding, not disease management, but health management of individuals. Could you maybe give us a bit of a sense of your perspective, your contribution on how is the organization of care in Europe would be and would have to be?
Thank you, Omar. Let me also start highlighting that in the few minutes that I will be speaking, more than 20 people will die for diabetes and its complication. And the vast majority of them will die because the healthcare system cannot manage the complication in a way that is more effective. So starting from this and highlighting the urgency to act, I can share that, for example, in the last years, we carry out an analysis, for example, on the new molecule launched in the diabetes arena and available for the patient. And from the period 2014 to 2020, we counted the 17 new molecules potentially available across Europe. And the result of this analysis highlighted that no single state had all the 17 molecules for the patient, available for the patient and the healthcare professional and the healthcare system. And also there was a huge variances from 3 months to over 4 years for the availability of some of them. So obviously these will imply a significant inequality of access to care. Because as Professor De Prato highlighted, that the last 10 years have been incredible 10 years full of innovation, both in terms of treatment availability as well as device, but also understanding how to manage the disease in order to improve outcomes. And the recent guidelines are just evidence-based indication for how to do it. Obviously, the lack of access of innovative treatment can significantly jeopardize the opportunity to make a difference at people's level.
Thank you. I think that contribution was absolutely necessary. Maybe Sandra, just a brief allusion to, if I could give the microphone for just a minute or two, because we need to move on with the other topics. But could you maybe tell us, from your perspective, what's the patient's, what would be the patient's role in that, improving the understanding to access the therapies, improving their own education on what to ask for, how to seek care, how to expand their life horizon, not just attend to their chronic conditions, but actually their whole longevity of their care? Anything that you would need to address in that perspective?
Well, I think good morning to all, and welcome to invite me to this webinar. I think all this in conversation need to focus on the patient. The patient is the important actor in the illness of the diabetes. So when we are talking about more education to improve health literacy and all this stuff, it's completely important to do that. And I must say that sometimes we put a lot of effort, time and money in knowing for new drugs and if they are effective or not effective. And we are missing the really good point. And is that these patients are taking these pills, because every time that a patient is coming to my association, it's saying, well, I have diabetes type 2, but it's just a little bit of sugar. So when a person is answering this, we know in the association that maybe we are doing something wrong, because it's not some sugar, and that's all. So it is important education, and it's important to know that if a patient needs to be healthy and want to take the pill, and if we want really a nice adherence, what we have to do is motivate this patient. It's through the motivation and not the obedience that you can get something. So it is really important, these 2 points. First of all, the main actor is the patient. This patient needs to be expert. It's time to avoid the paternalistic relation. And the second one, we need a patient that is really motivated. If this person is not motivated, then we cannot get success in diabetes. I must say that the statistics says almost 50% of diabetes type 2, the ones who are taking oral antidiabetics, the first 6 months, they are forgetting about the medication. And insulins is about 25%. So it's time just to focus on the adherence and to focus on the expert patient.
What a wonderful topic you're raising, and thank you for that. I think the motivation of the healthcare professionals will focus on, but I think motivation of the, let's not call them patients, because we talk about a group of people who live with diabetes, but also a group of people who may be leading towards diabetes that we want to care for. It's not just the, patients with emerging chronic conditions, but even beforehand. Now, Maurizio, I think some really important diagnostic points. Now, obviously, about 6-7 months ago, that's the time when you said we need to dive deeper into this topic. We do understand some of the pillars, but we do not need to understand and categorize and systemically approach the policy barriers. Maybe you can tell me the story on why you've decided to have this 3-pillar approach and obviously initiated this report together with PwC.
Thank you, Omar. Very nice question. Exactly 6 months ago, we started from the fact that from one end, we had this huge unmet need. Diabetes with 1 death out of 5 seconds, but also think about 1.1 million of death just in Europe. And without mentioning that diabetes is the second highest cause of loss of health. Together also that usually a person with diabetes lose 2.6 years of productive life versus a person on diabetes. So from one end, Omar, we had this significant unmet need. On the other end, we knew that even the most well-educated and the most motivated, well-educated healthcare professional and most engaged and motivated, well-informed person with diabetes struggle to follow the recent evidence, as Professor Del Prato highlighted. And we know that now we know how to manage diabetes. So we wanted to double click on how easy it was for a healthcare professional to follow the guidelines based on the evidence. And we were missing the magnitude of the issue. And as Teresa Vittoria highlighted in the intro, was clear from this report that it's almost impossible to be able to follow the guidelines for several barriers that are not only healthcare professional education, they are policy barriers. There are guidelines that at local level are translated in a different way than the scientific international one. There are administrative and process barriers. There are access barriers. And I would like also to link to what Sandra just highlighted. We need to have multiple options in place, and we need to provide multiple options really to personalize the care, to make sure that there is the best adherence as possible based on the healthcare professional needs, but also with the person with diabetes needs. And that's why it's very important to ensure that these options are available. And let me also frame one element that, if I can, Omer, we need to also start from the consideration that out of the overall cost of diabetes, the pharmaceutical costs are only 10%. The other 90% are cost-driven by complication. And there are good analyses highlighting that up to 75% of these 90% of the cost are preventable if we could do better as a community, a better job in managing complication. That's also a good framing for understanding that while we understand that there are some cost containment measure at local level to minimize or that are going to impact the guideline execution, on the other side, we need also to consider that the cost of diabetes is essentially complication driven and will be skyrocketing if we don't act properly now with a more strategic approach. But I don't want to skip in a different session.
Actually, I have to say, as a health economist, as trained health economist, if I could add, we are actually underestimating these costs, as we understand more on the inflammatory mechanisms and diabetes impact on several different diseases, including Alzheimer's and dementia and other neurological disorders. We actually are facing a much higher, much more impossible to neglect cost before our eyes. So I would like to come to Stefano one more time to you as a practicing physician, as someone who cares for patients, but also people who are in progression perhaps to diabetes. May I ask you, it's very clear from Maurizio, from Sandra, it's a very complicated disease we're dealing with. It's not a straightforward take the pill and get better disease. The patients need to be educated, the physicians need to be educated. What are the barriers that are further shoved on the way of our fellow physicians, fellow healthcare workers, to make that complication even more complicated via policy barriers that prevent them perhaps to utilize the treatments on time, utilize the right therapies as needed, and maybe allow the patients to have the cognition that they may need to utilize different types of therapies? What would be these barriers from your point of view?
Omar, I think we are discussing about the European situation. The simple fact is that the European situation is not homogeneous. It's very heterogeneous. And heterogeneity refers to the different indication or approval or reimbursement process from country to country that results in a dissociation between guidelines and what is the local way to deliver care for diabetes. And I think this is one of the major burdens that we have. How this translates into practical examples, for instance, different times in implementing what is the decision of EMA at the level of the different countries. When this happened, special regulation in the country in terms of limitation for prescription, different of segmentation of the diabetes population according to some criteria, body weight, degree of hyperglycemia to start with, and so on. The requirement, I'm from Italy, we still have to write what we call the piano terapeutico, that is, the specialist needed to sort of give a blessing to the general practitioner in order to start and continue for some of the innovation that are made available to the people with the diabetes. So those are the things. So maybe what we need to do, and actually the European Association for the Study of Diabetes is working on that, is rather than having, different regulation, different recommendation, just to have an European guideline for the treatment of diabetes that has been written up with all the requirements to really make it an official and respected guidelines, just to allow every country in Europe to have a reference point. And in trying along that to really harmonize what is the local regulation and the local implementation guidelines, what is the overall indication derived from the evidence. I think these are the thing that we need really to consider. We need really to come to a more homogeneous approach, an homogeneous approach that sticks to the best of its possibility for what is the recommendation generated by the evidence.
I think, thank you. I think there's a great segue to my question to Sandra. Now, Stefano has identified the practical issues, but also the issues that are emerging from the lack of harmonization across Europe, therefore patients not receiving equitable care across different locations in Europe. But Sandra, may I maybe ask you, what is your perspective on the actual knowledge of the patients, people with diabetes, and their information, their level of information, what they can access, what is actually available to them? Do you think these policy barriers are also preventing the right level of reinforcement at the patient level from healthcare professionals, but also from the healthcare system on its own? So they do not actually be able to understand what would be available to them to improve their longevity potential and avoid any acute or chronic illness on their path.
Well, I will just say an example. The person with diabetes type 2, they take care on the primary care center. The doctor, they only have approximately between 5 to 7 minutes to take care of him or her, just to give the information, the menu, the motivation, the adherence, all this stuff. So do you think, is it possible, this kind of empowerment to the patient, if they have only 5 minutes per year to give all this information? So the important thing is, I think that obviously they don't know all the options that they have. The adherence is really low, and they need more. They need more motivation. They need more information. They need more education, and one of the important points here is the associations. The associations, we can do a lot of things because the professional ones, they don't arrive. They don't have time to do that. So it is important for the association just to give this information, more time to give to the patient in case of diabetes. It is not possible just 5 minutes per year. And the second one, we always have this relation between doctor and patient, and that's all, between this communication. But sometimes in type 2, there are people that they have cognitive problems, that they have maybe mental issues. So sometimes it's really important, the family, the associations, the pharmacies, the hospital, all these staff, all these professionals need to be sharing the information and the data, because sometimes the information that they have only the doctor and the patient, it's not enough in case of type 2. So this is really important. All the actors in the same function to get to this patient all the information and the take care that they need.
Absolutely. We're all on the same boat on that. But maybe I'd like you to carry on this line of thought, if Mauricio and Stefano allow me, Sandra. So these issues are clear. Let's talk a little bit about what could be done. And I specifically want to ask you, because you said just a few minutes ago, you said we cannot neglect patients. Patients are at the center of it. In fact, we call these group of people, let's not call all of them patients. There's a broader group we're dealing with. We want to avoid them becoming patients. That's very crucial. We're talking about their longevity and avoidance of acute and chronic problems in their health. What could the patient community do? How's their enablement currently to actually have an impact as advocates initially for their own care, but for the care of their population? You know, again, alluding to what Stefano said, to this dishomogeneous way of care across Europe. Any success stories, anything that actually worked with politicians, with local, national, pan-European politicians, anything that encourage us?
In fact, I think that one society has success in diabetes when they have 3 points. The first one is when at least one responsible health professional expert knows about diabetes. So the second one, training initiative related with self-care of expert patient. And the third one, training programs related with diabetes to professionals. And when you have these 3 keys, then you get more option to have a good management of this illness. So when you have these 3 points, you probably will have a better prevalence of diabetes and better statistics. And in case of Europe, and examples, for example, are in Scandinavian countries and in United Kingdom. in Spain, I can say that it's really no possibilities in that moment to have these 3 points. We are working on that, but it's really complicated. Maybe in other countries, Mauricio, Italy, or you can tell us if it's better implementing of public policies related with this, with diabetes.
I was actually going to ask that both to Maurizio and Stefano. Maybe we can start with Maurizio. Any systemic suggestions from your side, Maurizio? Of course, I like the three-pronged approach Sandra is suggesting, but what could be done systematically? And then I will ask the same question to you, Stefano, if you allow me.
Let me also ask for the perspective of Sandra and Professor Del Prato on these, but I would say that starting from the fact that non-communicable disease are 80% of the European problem and burden, in counting 90% of the total death. The key fundamental question is that our healthcare system are equipped and structured to manage non-communicable disease. And we think that they are not, because they are essentially equipped and adapted for the acute phase, not for the chronic phase. And we need to shift from acute setting, hospital-based, to a more long-term, territory-based, integrated care approach. Let me give you some concrete example. Do we really think that a separation of a pharmaceutical budget, a territorial budget, makes sense when a lot of the treatment have benefit and impact in the long term? Professor Del Prato highlighted one element that is important. In the last 10 years, we moved from a glucocentric approach to a more holistic patient-centric approach with product that has not only the glucose lowering effect, but also renal, cardiometabolic protection, dramatic weight reduction. Do we think that this segregation of budget and cost makes sense for having an holistic patient-centric care? We believe that it's not possible to be effective if we have this barrier in place. We still believe, obviously, there is a conflict of interest here, but we believe that the excess focus on pharmaceutical expenditure will not solve the problem of healthcare system skyrocketing, because as we said, 90% in diabetes is complication-driven. If we don't do a better job in managing complication, we will have always healthcare system increasing the expenditure. That's why we need to have also a switch in healthcare as investment and investment on pharmaceutical innovative treatment, able to prevent or limit or delay the complication as an investment and as not as a cost. And the last but not the least, I would also suggest to have incentive based on health outcome and not incentive on disease. We have reimbursability linked to BMI, for example. So a good healthcare team that is reducing the BMI beyond the threshold risk to lose the reimbursability of the drug. That's a paradox that we need to solve. The intention might be good, but the impact is totally different from the original intention.
That lays out the land really well. But I think, Stefano, maybe as a top academic and as a practicing physician yourself, maybe we can have your thoughts. And may I please remind you, at 1 o'clock, we're going to have the Honourable Gentleman, Ishwan UAE, to join us, hopefully. But we still have a lot to talk about. And Stefano, please,
yeah, I mean,
your thoughts.
I mean, you were asking, what can be done at a systemic level. Sandra just mentioned before what is the important, essential advocacy role of the association. But, I think that we need to come all together to raise our voice. And it's the voice of the people with diabetes, is the voice of the professional healthcare providers, is the voice of every stakeholder involved in diabetes. Because, Omar, you mentioned something before. Diabetes is a complex condition. Diabetes is not perceived like that. Diabetes, and particularly type 2 diabetes, I'm afraid to say also, to some extent, also by the administrators, by the political power, is still considered a sort of a self-inflicted condition. People don't pay attention to what they eat, how much they eat. They don't do any exercise. Why should we pay for people not behaving? This is not the case. Diabetes is a serious condition, and it's too bad that people consider that diabetes becomes a condition once you get complicated. Okay, so that is what the change. Now, this was one thing. So we need to come together. And in order to facilitate this getting together, now we have the European Diabetes Forum that really brings in all the different components in the field of diabetes. Is the scientific component of it, the ESD, the EFSD, the Association of the Scientists and the Physician. Is the people with an interest and advocating for type 1 diabetes, because remember, it's not only type 2 diabetes. The type 2 is the big bulk of it, but diabetes is even larger than that. And with a very heterogeneous needs for each one of these individuals. That brings in all the different components in the field, just to work together in order really to increase and just to have a unified voice to really call for attention on what is going to be. I'm not a pessimistic guy, I really like to look at that in an optimistic. I hate repeating myself. Diabetes, are exposed to this risk and risk, they're going to cost and so and so and so. I think that we have to be optimistic. We have now the chances to make the life of many people much better than has been in the past. And I think this should be part of the duty of the political agenda in Europe. I think this is essential. So the UDF is trying to do this. And the UDF also, the European Diabetes Forum, is trying to do that along some practical and pragmatic action. So what we have been trying to say, as I mentioned before, heterogeneity across Europe. Let's get the data about that heterogeneity. Let's get as many as possible, if not all the country, to start to collect properly data so we can compare. So we can say, we improved. We improved in Italy. We have been improving in Sweden. We have been improving in the Central Europe, in the Eastern Europe, in the Western Europe, or whatever. But this is a way. So data registry to really monitor how good we are doing. Let's keep it positive. How good we are doing, not how bad. How good we are doing. Okay, because all we are trying to do is to improve it. The other thing is integration, and integration is an important one. Integration is an incredible concept. Is an integration of all the stakeholders. Is integration with the people with diabetes. I like very much, Sandra saying we need to forget about this paternalistic approach. But I don't like also the paternalistic approach for my policy maker on me. I want also to say my view, right? It's the same kind of approach. It's the same kind of integration that we need. It's integration with the primary care physician. And I think that integration can become instrumental to reconsider the way we are delivering care for diabetes, because delivery of care of diabetes cannot be done, Sandra, as you said, in 7 minutes by speaking with people. In 7 minutes, it's just enough to say, good morning, how are you? And the time is gone. This is not the way. We need to really. And the other thing, we need also to look at a way to facilitate this approach. And that is the role potentially of the technology, the digitalization. We are coming out of this COVID-19 pandemic. We need to learn from it. We need to learn and to see how good we can really extract out of that experience. And I think that digitalization is something that we can learn from. But it must be digitalization, telemedicine, or whatever you want to consider, the use of apps, supported assistance to patients, supported, decision making for physicians as well, in a very, solid manner. It cannot be just overlooked. It must be part of a change in the way we really deal with the delivery of care for people with diabetes. So those are the systemic approaches that I could see. And the other thing that we need to do is to improve our ability to not have too many people walking around with diabetes without knowing to have diabetes. Improving the screening, improving the identification, and not only for type 2 diabetes, but even more in the future for type 1 diabetes, because we may have also better solutions. So I would say that there are at least 4 items we can work all together on that. And that is the registry, data collection, the integration, the digitalization, the screening.
I think you could not be clear enough. I think we are at a very important juncture. The launch of Darwin EU system, which is going to hopefully by 2025 is going to aim to integrate data processes across Europe, is very important. Then, of course, the Innovative Medicines Initiative, one of the giant initiatives across the world. Europe leads the way in integrating the industry together with policymakers are crucial. Of course, the establishment of Berlin Hub by WHO, led by the German government, funding future surveillance methods. I think diabetes community, led by yourselves, should take heed and should be integrated with, as you very rightfully said in your second point, the importance of data, importance of integration, importance of digital usage of digital data collection and action. And you very rightfully said, we do need to understand the broader impact of diagnostics and how to actually recognize, I am underlining one more time to elevate the importance. We're not dealing with patients necessarily. We're dealing with improving people's lives and their longevity. These are patients, not patients. These are people living with diabetes or patients who have the problem or who may run into a problem with their blood glucose levels, but even other aspects of their life that can lead to diabetes. And I think this week, the European Public Health, we've attends to all of these issues rightfully in 5 days. Sandra, I will turn to you. Very encouraging 4 policy areas. You've brought your 3 pillars to attention. Thank you for that. What would you do, taking heed from the reports, but also taking heed from our diagnostics on policy barriers, as Maurizio initiated that and the group in EFPIA initiated that research? What would you do differently? How would you congregate with your common advocates community across Europe? How do we attend to these issues as a patient community?
Well, I would say that an advisory council in charge of promoting, coordinating, that really works. And if this advisory council works and must have transversal policies for prevention and must be promoting healthy lifestyle habits, must be working on an expert patient program. It's plenty. I mean, it's really a complicated question to answer, but first of all, it's like Stefano Maurizio says, I mean, we have to work together. We have to think that there is not only a patient or a doctor, it's all the agents that need to work. And we have a lot of homework to do. So it's time just to coordinate.
As you've passed the ball to Maurizio, may I please give the word to you, Maurizio? I think this is very important. It needs to be mentioned. Yes, we need to diagnose. Yes, we need to survey. Yes, we need to deploy digital therapeutics, digital ways of looking at it. And we need to do this with having access to the most up-to-date, most precious data. But the innovation that comes to the market, what is your perspective on, are there any good news in diabetes management in terms of innovation? Which improvements some of the novel therapies bring, in your opinion? Of course, there's papers abound these days. I would love it if you could address that briefly from EFPIA's perspective, also from your point of view, please.
I think that the future cannot be brighter in terms of new treatment, innovative approach. They are potentially available. And as Stefano highlighted extremely well, in the last years, we moved from being essentially glucocentric and with the effect of glucose lowering to really cardiometabolic protection, cardiorenal protection, dramatic weight reduction, and so on. So there is really promising treatment available and in the future available. But we know that even the best of this treatment cannot be the solution, should be part of the solution, has been highlighted, and should be fitting very well in a system that knows how to cope with non-communicable disease, with chronic condition. And I don't want to echo Professor Del Prato and Sandra on some of the topic. So definitely there is a significant opportunity to pick. On the other side, we see also some clouds, I have to say, as a EFPIA. And I'm referring, for example, that the current recent proposal of pharma legislation can really impact the definition of innovation and limit, because, for example, the narrow definition of unmet medical need can be a risk in the future for really making these all opportunity fully available, and as we are committed to. So, but definitely great opportunity and promising treatment in front of us. Some work to do in order to enable the healthcare system to cope better with disease like diabetes.
I will maybe, as we're waiting for the honourable gentleman, maybe I'll pass the ball to Sandra and to Stefano slightly. What I want to ask you both is, following on through the fairly positive prospects, and I think anyone who follows not just the literature in PubMed, but anyone who follows the news, there was even an article in the Atlantic magazine, a fairly general public magazine that I happen to read very often. There was even articles on how diabetes, some of the drugs that attend to diabetes management, how they improve the general mental well-being, general addictive situation of some of the patients. So there's the literature's abound. It's multitude of different research coming through. The new treatments are available. How do we make sure, maybe starting with Stefano and then ending with Sandra at this point, how do we make sure that the physicians, the healthcare professionals understand in this very complex problem, how could they be further enabled to deploy these therapies as fit? And, I would love to have any prescriptive suggestions from you, both Stefano and Sandra. But of course, we could also talk about the wider policy implications. I'd love to have your thoughts. Stefano, with you first, and then maybe Sandra.
Yeah, and I think the audience has a question for the speakers that say something like...
towards the end. I will come to that towards the end, if that's okay. I want to, because that's a very important point raised. I would like to address this, and then I will come to the question. Stefano, shall we start with you with a minute, maybe, if possible?
Omar, I can also have a very simple answer. Doctors need to be good doctors, right? And being a good doctor means to be knowledgeable of what is out there in terms of diagnostic and in terms of the treatments. And I do believe that the majority of doctors are indeed good doctors. So what we need to do is really to facilitate their uptake and the implementation of the guidelines. I think this is the most important thing, because if we are sure, that is implemented, it is also easier to identify which are the drawbacks where we need to work with respect to physicians and doctors. I think that's important. Of course, education is important. And education means a lot of things. It means realizing how serious is the condition. Means realizing that, that what has been used to say in the old days, our ancestors, is still actually true. I mean, I'm from Italy, right? My ancestors are Romans, Latins, And Latins used to say, and I say that in English because I mean my Latin memories are bad enough. It was Publius Ovidius Naso who said, "At its beginnings, it's too late for the doctor to be called when the illness has grown stronger through delay." So this is the message. And we have now better way to stop the progression of this condition. And we needed to make the people put the people in the condition to really take advantage. And we need to do that. Not only just saying they could take advantage, but they needed to do that in a responsible manner. They need to be made responsible for using the right treatment to the right person at the right time. And it needs to be done in terms of responsibility of the physician. I'm not, taking the responsibility out of the shoulder of the physician. They should have, put in the condition to work the best of the way they could do, but that they needed to be called to their own responsibility. And they need to work together with the people with diabetes in order to solve the issues. In modern diabetology, started off in the United States, in Oxford, when there was this famous diabetologist who used to say, if you want to treat properly a person with diabetes, you need more than one brain. And I interpret that to say, you need the brain of the doctor and you need the brain of your person with diabetes. And the two brains needs to come on the same wavelength to really come to best result. But the surrounding, the environment needed to allow this to happen.
And we also need the brains of people who lead us in our communities, in our societies, in our wide continent. And I'm very happy to announce that honorable gentleman, Mr. Ishtwan Uey. Ishtwan, good morning, good day. I think you're with us, I understand, from our operators. Did I misunderstand? I was informed that he was with us. Okay, well, that's I'm hoping it's a technical issue because we were really looking forward to having his perspective.
Okay, if you want, I can answer the question.
Please, Sandra, forgive me if I cut you off in the middle if Ishtwan joins us.
I completely agree with Stefano. I would say good doctors. I would say training. And, well, to the question of the sentence of good doctors, I always ask, when you were young, why you wanted to be a doctor? And about what you answer, then you will know exactly if you are a good one or not. So this is the first thing. And the second, as you said, people with diabetes, they are thinking like more than 100 decisions per day. So they need help. We need help. So all the stakeholders need to be together because 100 decisions for only one brain is too much. So we need to be together.
Great. I on that point, that's a very good timing, Sandra. The honourable gentleman, Mr. Ishtwan Uey. Ishtwan, good morning, good day. Thank you for making the time to join us from your, I'm sure, hugely busy schedule, especially on the European Public Health Week. If you're with us, I understand you're with us. Could I please maybe have a few words from you, from a policymaker perspective, as someone who actually is in the team of MEPs who are dedicated to diabetes care across Europe? Ishtwan, can you hear me? I can't hear you.
We are thinking about the question.
No, I'm sorry, Sandra. The question isn't to you. The question is to Ishtwan, the member of the European Parliament, who I was led to believe was with us. I'm very sorry for this technical hiccup. Yes, please.
I don't know if you have time to deal, but there are a couple of questions from the audience. I don't know.
I have noted them. I think Julian's question is very interesting. Obviously, Christina Castro is asking us on not just the diabetes, but diabetes is in a world of different problems. Obesity is one of them, and she's particularly referring to that. And of course, several very innovative therapies we all know are deployed for several different purposes, to obviously maintain well-being, but also maintain a good BMI score. And even though BMI score for individuals' care is less effective, perhaps, but obviously the tackling with obesity is very important. I'll let you address these questions, Stefano. I'm just within the limited time, we really wanted to have Mr. Huey with us and have his thoughts. As you know, a lot of our remarks in the report are actually targeting the policymakers. It'd be great to have them, respond to some of our suggestions. But
Omar, if you allow me,
please.
If the policymakers can count on us, we're ready to work with them.
I think that is honestly, Stefano, I have to say, I know I come from the private sector. I'm a partner at PwC, as I mentioned before, but this topic motivates my team. And I have about 65 people only in Switzerland focusing on health policy and health industry related topics. Of all the projects that we do, when we talk about the prospect of changing healthy people's lives, making them healthier, not patients, I have to say I have my colleagues lining up to join the project. This particular congregation of activities with Maurizio's team, thank you for that, for enabling us to work with you, was such a motivator. And you're very right. It's not just you, the health practitioners. It's not just you, the people suffering from the causations of diabetes, pre or post. It's not just you, Maurizio, who's a member of the industry. This is a wider public. All my colleagues, as educated enthusiasts of public health, we are all ready to contribute to this giant problem. And if we don't tackle it, it's going to cost. Mauricio underlined the health economic costs. But again, with his permission, I was maybe disrespectful. I said, Mauricio, you're underestimating these costs, because the more we know on the vascular consequences, the more we know on the inflammatory consequences, the more we know on the mental health consequences of diabetes, of the path leading to diabetes. It's not just diabetes alone either. It's the whole path leading to that. And the cost of it is, unfortunately, I'm a health economist, but I don't think I could take the task to calculate it. It's so much more than what we anticipated to be. And if Ishwan was with us, I am certain he would have said that he is doing his best to address these issues at the European Parliament, but we can't seem to get him in. Now, operators, I'm going to make a call here. I'm afraid we only have 3 minutes, and I don't want to waste the audience's time. And Christina and Julian, I think, Maurizio, you rightfully said we do need to address the audience's questions. If in the meantime Ishwan becomes available, please project him to the screen. We'll pause and we'll let him say his piece, but otherwise there's no point in waiting any longer. Julian asks specifically on your thoughts, and I will give this, Stefano, to you first, obviously, on the promising therapies. Which ones for you will make the biggest change, if you want to specifically mention? And maybe then Sandra, Maurizio, you can maybe talk about the wider consequences of diabetes treatment. Christina is mentioning particularly the obesity impact and the discussion surrounding obesity. I'd love to have your thoughts. But if you can keep it to a minute, Stefano and Sandra and Maurizio, that would be great.
Omar, to Julian's question, I don't like to make a ranking for this, what is more important and so on and so forth. For instance, here you have solution for people with type 1 diabetes, the closed loop system, and the diagnostic procedure can really impact every person with diabetes, which is, the screening for diabetic retinopathy. Let's say that we do count on a continuous progress of the technology, and technologies means, the physical technologies, or the technology applied to pharmacology and so on and so forth, to really move forward. And I think, if I look back, I'm an old diabetologist. I've been in the field for more than 40 years. What I've been very lucky about is to see how things has been revolutionizing over the time. I used to say, when I started off to be a diabetologist, I used to treat people with diabetes with just 2-3 drugs. Now I'm fortunate. I want to be a specialist, able to use the technology for diagnosis and the technology for the treatment of diabetes in a more efficient manner.
Maybe that, Maurizio, Dante Salvador rightfully said her question is very complicated. I definitely understand, and I, as a physician, I'm aware of the biological consequences of that question. But the industry is, of course, working on not just diabetes, on the whole consequences as a whole. Christina was specifically referring to the obesity-related consequences. Do you want to say a few words on the industry's thinking, or the FPIA's thinking, on addressing this giant ball of problems of diabetes, not just the actual glucose mechanism, as Stefano very rightfully said, which is not what we only focus on anymore. So any good news, any attitude, attention, any few words, that'd be great. And then I'll pass to Sandra.
Microphone. Okay, here we go. Omer, thank you for the question. Let me tell you that, let me reiterate what has been previously said. Exciting news for moving from just the glucocentric approach to end organ protection. So with cardiometabolic, cardiorenal, dramatic weight reduction. In terms of list, honestly, I believe that there is no the rank for doing it, because any person with diabetes needs is key. And we need to have multiple options for really addressing these dramatic cause. And just a confirmation of what has been said, establishing a good dialogue and addressing all the concern and barriers, the only way to make a difference. Because the big disappointment is that we have the tool, we have the diagnostic elements, as has been highlighted, we have the possibility to treat effectively. But we need also to have a local level, a country level, where healthcare system, where healthcare is managed, clinical practice that are aligned with the most evidence-based information in order to drive really a change. So that's my final comment too.
That's thank you very much, Sandra. I'm extending, with your permission, another few minutes, just in case if Ishwan can join us. We're supposed to finish at 1:15, but let's carry on till 20 past, if our audience could be patient enough with us. Sandra, did you have any last remarks in this particular instance on new therapies, their availability, how patients should be aware of them?
Can you listen? Yeah. We were talking all the time about diabetes, but we have missing one word that is really important: pandemia. So it's a lot of persons that, I mean, it's increasing maybe 10% each year, and it's a lot of population that they have problems with this illness. So I will say that we have to work together, and that obviously the policymakers need to do something. It's not an illness of a reduced population. It's increasing and increasing every year. So diabetes is pandemia. So it's important to know that.
I think that really puts the final very important seal on our conversation today. With the permission of our audience and our esteemed speakers, I did extend the time a little bit with the hope that honorable gentleman Ishwan UAE could join us. I'm sure if he were to join us, he would have said that he will read our report with interest, as I hope all of the members in the audience joining us today will do so too. We're very open to criticism, naturally. We're very open to suggestions, naturally, and we're very open to speaking with anyone who is ready to either tactically, meaning, take up a few of the small suggestions we make and come up with ideas and ask us how we can actually facilitate the creation of that platform. We can do this as PwC, but obviously Stefan has a very powerful platform, so does Maurizio, and so does Sandra. So all of us, I'm sure, please allow me, speakers, on your behalf, I'm promising that we'd be delighted to come back to anyone who reads the report and has commentary, and especially has tactical suggestions on how to maybe adhere to the way of thinking of the policymakers at the European Parliament level, but more importantly, maybe at the local level, more importantly, maybe at the national level, more importantly, maybe at the community level, to be able to tackle this, what Sandra rightfully referred to as a massive pandemic, which, dare I say it, and that's my own personal perspective, in my opinion, is much bigger, much wider than what we experienced with COVID 2-3 years ago. So I think that recognition and that need for that recognition and need for tactical, discrete action, you've all underlined. Thank you for all of those who've joined us today. Thank you for spending your time with us. Hopefully you've felt the dedicated notes of all the attendants today, and hopefully you'll come back to us with commentary, criticism, ideas, suggestions, tactical thoughts. I want to underline one more time, so that we can, in a congregated manner, in a united manner, go and talk to our colleagues and members of the Parliament and the wider policy community. Thanks very much, everybody. Have a great day and have a great European Public Health Week.
Thank you.